Everyone, we'll go ahead and get started. I'm really excited to welcome all of you to this very special event, welcoming you here in the Sullivan classroom and as well as our audience on Zoom. Our topic today is global perspectives on health. And to be led in this topic, we're really lucky to have one of our own, Dr. Mitchell Wolfe, who began his medical career here at this institution as a member of our medical school class of 1995. He's since gone on to a distinguished career in preventive medicine and public health, and today is the Chief Medical Officer of the Centers of Disease Control and Prevention based in Atlanta, Georgia. Of course, during the pandemic, we've been hearing a lot from the CDC. Dr. Wolfe has also, throughout his career, been involved in global health issues, including CDC the Global AIDS Program. He's also served the CDC as a medical epidemiologist and led the clinical outcomes team and behavioral and clinical surveillance branch of the National Center for HIV, AIDS, viral hepatitis, STD, and TB prevention. He's also contributed the bioterrorism preparedness and response branch of the CDC, supporting its response to the anthrax attacks after 2001. In addition to his UVM medical degree, Dr. Wolfe earned an M.P.H degree from the University of California, Berkeley. In 2020, Dr. Wolfe retired his commissioned role in the Commissioned Corps of the United States Public Health Service at the rank of Rear Admiral. We're so glad to welcome Dr. Wolfe back to where he began his medical career. And we've really enjoyed hearing stories and getting to witness his reconnecting with old friends and actually some of his faculty. I must note that Dr. Wolfe's appearance today is in his personal capacity as an alumnus of this college, not in his official role with the CDC. Now today already, Dr. Wolfe has had the opportunity to visit with our community, including some fellow members of the class of 1995 who are members of our faculty. He's also met with the Translational Global Infectious Disease Research Center group and has interacted with a number of our students, both the class of 24 and the class of 25. So welcome, Dr. Wolfe. It's great to have you back. Now we have a number of illustrious individuals I'll be introducing in just a moment. I will like to make note that we're flattered that Dean Noma Anderson from the College of Nursing and Health Sciences is joining us here today. Welcome, Dr. Anderson, who's also joined us during a pandemic. I think we may have seen each other once or twice without a mask on, other than Zoom, but it's great to have you here, Dean Anderson. We have another special guest with us today, who's actually a professor of medicine in our college and commissioner of health for the state of Vermont, Dr. Mark Levine. In addition to his role as a faculty member since 1992, Dr. Levine has practiced internal medicine and served as our associate dean for graduate medical education, as designated institutional officer at UVM Medical Center and vice chair for education in the Department of Medicine. Dr. Levine has served as commissioner since 2017, and over the past 2 years has become familiar to all Vermonters and even nationally as he's guided our state through the COVID-19 pandemic. Throughout this difficult time, Dr. Levine has worked closely with many of us in the college, the university, and our partners at the UVM Medical Center and Health Network, and we're so glad that he could join us here today. Also on our panel, I'd like to introduce Dr. Jan Carney, a former commissioner of health for the state of Vermont, who served in that capacity under 3 different governors from '89 to 2003. She championed improvements in children's health insurance, preventing teen smoking, and improving cancer screening. And today she's professor of medicine and associate dean for public health and health policy and senior advisor to the dean here at our college. She also directs a very successful master's in public health degree program. Other panelists we're honored to welcome include Dr. Beth Kirkpatrick, professor and chair of our Department of Microbiology and Molecular Genetics. She also serves as director of the UVM Vaccine Testing Center. Dr. Kirkpatrick is also principal investigator and director of UVM's Translational Global Infectious Disease Research Center and NIH COBRA, or Center for Biomedical Research Excellence, which was founded in 2018. Her research is focused on vaccine development and human immune responses to vaccines, with particular focus on dengue and enteric infections. With the current pandemic, she and Dr. Carney have served as valued advisors to our college and our university. And finally, Dr. Stephen Leffler. Dr. Leffler is a member of our college class of 1990 and actually helped Dr. Wolfe put in a chest tube when he was a medical student, apparently. He serves as President and Chief Medical Officer of the University of Vermont Medical Center, a position he's held since 2020. Dr. Leffler has worked as an emergency department physician for 25 years and is professor of surgery at our college. During his career, Dr. Leffler has worn many hats, serving as Chief Population Health and Quality Officer, Chief Medical Officer at the Medical Center, and Medical Director of the Emergency Department. He's also past president of our medical staff and the Vermont Medical Society. Throughout my time as dean of this college, and particularly through many complicated situations in the last 22 months, Dr. Leffler has been a stalwart friend and partner in our shared missions, and we're all grateful for the leadership he provides during these difficult days. So what a dream team of panelists for this important session today. Now that you've learned a little bit about each of them, I'll be asking some questions, and I'll be joined by Dr. Kirkpatrick and Dr. Carney as we ask questions that we've prepared for our panelists. And then we're going to leave plenty of time for questions from the audience, both here in Sullivan and those who provide questions through the Q&A function on Zoom. And I'm going to start off with a question that I've asked each panelist to be relatively succinct just as we get things going. And I'll start with Dr. Wolfe. What in your career prepared you to be ready to serve the position you're in during really being in the eye of the storm of a worldwide pandemic? Dr. Wolfe?
Sure, thanks. And thanks for having me here. I've not been back since graduation day in 1995. So it's really great to be back here with everyone. I think there's two things that have prepared me the most. One are the people that I've worked with who have influenced me. And I just want to acknowledge a few doctors who are here, Dr. Allison Baldock and Dr. Buzz Land, and then one who wasn't able to make it, Dr. John Ferguson, who I worked with for a long time. And, you know, I was really affected by the physicians I worked with who demonstrated to me caring and dedication to health. The second, I think, is developing skills in areas that you may be more uncomfortable with. And I was talking with the medical students earlier, and they were asking kind of what skills do you think are important to be developed? And I said, whatever you're avoiding right now is probably the skill that you need to develop. And with me, it was public speaking, and I was not good at it, and it affected, you know, could have affected the ability to do my job, and I really worked on it hard for many years when I started at CDC. So I just think it's really important to try to focus in areas of skills that you need in order to be able to do your job in the future.
Great, thank you. Now, Dr. Levine, for you, what really prepared you to be in the eye of this storm?
Nothing. I could not have imagined 2 years like this. But no, in reality, the patients that were in my practice for decades allowed me to really explore the challenges of being a human being on the planet, of trying to enact behavioral lifestyle changes to really impact all of the things that adversely impact in our lives and that lead to all of the problems we have in society and in medicine, whether it be obesity, whether it be cardiovascular disease. substance use, tobacco abuse, et cetera. The list goes on and on. And the one-on-one practice and counseling in those sessions with patients was invaluable, but also illustrated to me with some further thought how shifting to a population level, I could perhaps have even more of an impact. Because on an individual level, you may actually change someone's life or have them help change their lives in a month or two. But usually it's several years. Sometimes it's actually decades, but you eventually get there. Sometimes on a population level, through using a lot of different levers, including policy, one can have a remarkable change much, much more quickly. Witness what we did in tobacco use and vaping just a couple of years ago with sort of a trifecta of new laws that really impact youth picking up of those adverse behaviors. So I think the ability to sort of look on a population level and to try to integrate public health and primary care actually ultimately helped prepare me for this. And I have colleagues to thank who are in a group that I actually helped name, but it was not a founding member of, called the Primary Care Public Health Integration Work Group, which actually every month meets people from this campus, the medical school, the medical center, specialty societies, and health department members, and try to, in collaboration, solve challenging public health problems. Never had the challenge of a pandemic before, but certainly one that they have been front and center with as well.
Thank you. Dean Carney, what prepared you to stand in the eye of this storm?
I think learning about the science that we can prevent some of the diseases that we often see as physicians after the fact. When I was a resident, I saw too many patients with diseases related to long-term tobacco use, lung cancer, serious heart disease. I mean, very sad. And I got a master in public health degree where I learned that there's a whole science of prevention, how we can prevent this. And I think having that science, it's epidemiology, it's many other sciences, helps to prepare you for whatever comes your way in public health.
Thank you. Dr. Kirkpatrick, what made you prepared to stand in the eye of this storm?
I guess like Dr. Levine, I'm not so sure how prepared I am, but I think. Although not to touch this. I guess really two things. One, I think my clinical training really helped. You know, I trained in clinical infectious disease after internal medicine. I did a lot of training in HIV, extra training in clinical tropical medicine. And I think that as a framework was a really good foundation. And my research has been in vaccines and clinical vaccine immunology. But I also think that one of the things prepared me is I have no qualms at all at confessing I don't know anything and cold calling someone up who does. And I'm the luxury of being surrounded by really smart, dedicated scientists in the Department of MMG and the Vaccine Testing Center with the Medical Center. And I think being able to triangulate some of the folks around here actually is something that I feel like knowing enough people and being here for long enough and cold calling people has really helped me prepare to be here at this moment.
Great. And finally, Dr. Leffler.
I'll start by saying that if you had told me when I was applying to be the president of the hospital that you were going to have to lead us through the pandemic for the first 2 years of doing that, I wouldn't have applied. I would have said, there's no way that I'm qualified to do that. What I thought I was signing up for was really different than what I've done. I talk about this in leadership a lot. I think a lot of leaders, you don't actually know what you're going to be doing. So I'll start by saying that I found myself here. And what I will tell you has helped me the most is I think that my medical education and being an ER doc has been very helpful. ER docs have to think on their feet, make decisions with limited information, but most importantly, and Beth already said this, collaborate with other people who have more knowledge than you and work together to find solutions for patients that can evolve quickly. And so I've worked with people on this table a lot of times around really complicated cases to figure out what's the best path forward with what we've got. And I think that's really been powerful for me, for the hospital, for the medical school, and for Vermont through this first part of the pandemic.
Great, thank you to all of you. So let's focus a little bit on the topic at hand, which is global health. And the Larner College of Medicine wishes to educate and train students who are globally minded. So with that in context, how do we do it? What are the key attributes that we need to instill in our medical students for the next generation, ready to address the global health needs that right now we can only imagine? I'll start with you, Dr. Wolfe, but then ask for others to join in and chat for just a few minutes here.
Thank you. I think this pandemic has really shown us what we've been saying for many years, which is the world is completely interconnected, and a threat anywhere is a threat everywhere. And I think that it's important to have the students realize that anything infectious disease related that happens anywhere is something that we need to deal with. And so we know that if we build capacity around the world, for example, for countries to prevent, detect, and respond to infectious disease threats, that will help protect us. So I think that exposing students to the field of public health and what it really means to be, what really the goals are, and how when we work from kind of a federal to a state to a community level and are aligned, we can really help affect the course of a pandemic are really important. So I think there are lessons even here in Vermont that can be applied to global health.
Right. Others. How do we make sure that our students are prepared? Dean Carney?
We put it in the curriculum. We have opportunities for our students. We have the things that are required and you have to learn, and then we have a lot of opportunities, and like today. And that we have electives and people who are passionate, knowledgeable about global health, and very accessible to our students.
So can I just follow on to something that you said is when I was a medical student here, I did during my elective rotations, I did a month in Scotland and a month in Ireland and a month in India. And it really helped me with kind of seeing what global health meant and what the different kinds of approaches are for different audiences and how really we're all connected. And so I just wanted to support that about the idea of doing electives to really get a great view of global health.
So Dr. Wolfe, that's really interesting to me that as a medical student, you saw fit to do 3 different international rotations. That's something. So you had this in mind early on when you went off to family medicine training for 1 year, or?
So I did. I was always interested in global health, and I didn't know how I was going to make that into a career. I thought that doing an international rotations would maybe help me see what I might be able to do, and also would be fun and interesting. So I'm really grateful for UVM. When I went and talked during residency and after with people from who had gone to other medical schools, they did not have that variety of opportunity. It was, I don't know if it's unique, but it was rare.
It certainly hasn't been happening lately.
Right. So I was really grateful that UVM was able to allow me to do that.
Any other panelists want to comment on how we prepare the physician workforce to face global health and public health issues to come?
So I think for many years, when I went to medical school here a really long time ago, we already had an innovative curriculum. We only spent 1.5 years in the classroom. And I've told many people who are thinking about applying here that there's many medical schools that can teach you how to take care of pneumonia, right? You can learn those kind of nuts and bolts things about being a doctor, but the medical school here gave you a lot more training in leadership, in being a teacher, in being a community advocate for health. And I think giving you the opportunity to broaden your perspective so you can do other amazing things like be chief medical officer for the CDC or other amazing careers. You don't learn that in medical school, but you learn the tools to, I think more broadly than just the nuts and bolts of how to take care of pneumonia or whatever. I think it's really important.
Thank you. So I've been up at the lectern long enough. We have 2 people who are much more expert in public health and infectious disease who are going to act as co-moderators. So next I'll ask Dean Carney to address some questions to the panel. Dean Carney.
Thank you, Dean Cage. All right. What lessons has the COVID-19 pandemic taught us about the importance of health equity and healthcare delivery locally and globally? How can we keep from repeating past mistakes that increase or perpetuate health inequity?
I guess I could start with that. Clearly in Vermont and the nation for that matter, we've seen case rates, hospitalization rates, and death rates nationally, but not in Vermont, higher in communities of color than in non-Hispanic white communities. We've known that there is a lot of reasoning behind why that is, a lot of rationale. Some of it has to do with greater propensity to live in multi-generational housing. Some of it has to do with being involved as a worker in a public-facing profession. Some of it has to involve taking public transportation to that public-facing profession job. Those are just probably tip of the iceberg kinds of things. The reality is, in Vermont, we recognized all of that, tried to respond to it, but so much of that is due to really a very long historical preceding process that one can't correct overnight. One thing we thought we could correct overnight was an important piece of data that we learned early on when vaccine became available, which was that our vaccination rates were highly discrepant when you compare the BIPOC community to non-Hispanic white. The uptake of vaccine was markedly different. And we thought there is a place we can actually do something real time that doesn't require correction of generations and sometimes centuries of injustice. And so we really worked on becoming a much more culturally humble, but also responsive health department, providing the appropriate communication and educational tools, interpretation tools, partnering in communities with trusted advocates and trusted partners who the community trusted, who would enable us to actually work with them in a very responsive way to provide more vaccine and more opportunities to get vaccinated. And all of that worked tremendously well and allowed us to almost erase the difference completely in the rates of vaccination. To take this to a global level, though, there's a whole bunch more that a state doesn't have to deal with. First of all, in the United States, we're blessed by being able to take scientific innovation and pretty quickly move it to practice. The rest of the world isn't always so lucky, as we found out, where we have tremendous access to vaccines in our country now for COVID, whereas in Africa, there are still countries that have perhaps 2% of their population vaccinated. So sharing in some of these dramatic research and medical innovations is one part. The other part is what I label implementation medicine, which is really how did we in Vermont become the best state to get vaccinated in and lead the nation? And how did our country, in at least pockets of our country, become leaders in doing that? And why can't everyone else around the world emulate that? Well, it all has to do with implementation medicine and how not only do you need this great resource of a new vaccine, but you need then to know how to actually deploy that, how to get the whole population vaccinated in a timely and efficient way and equitable way. And those are the challenges that need to be solved in the near and long-term future to really create the kind of global society that we're all looking for and protect us all for this pandemic and whenever the next pandemic occurs.
Thank you, Dr. Levine. Any of the other panelists like to answer this question?
Well, I would say a couple of things. One, from a global perspective, I think over 8 billion vaccine doses have been administered worldwide, and the global vaccination rate is about 54%, but there's a huge disparity between upper and lower income countries, and also just between regions and Africa. And so, like I said, I mean, I think this pandemic has shown us all about how interconnected the world is, and we need to have structures and processes in place that we can get these countermeasures everywhere that they need to be, not just to the most privileged. So it's really important. We have a strategy to help vaccinate. The U.S. has signed on to the global WHO strategy to try to get the world to 70% vaccination rate by mid-2022. It's a very ambitious goal, but it really is part of our trying to make sure that we get the whole world vaccinated, not just us.
If I may, I hope everyone listening recognizes that efforts to promote and ensure health equity is the right thing to do. But in addition, if I've learned anything from this pandemic, it's also the smart thing to do. The Delta came out of wherever it came from. Was it India, we believe? And why? Well, the horrors of what they were going through and the lack of vaccine availability throughout the world is only going to increase the number of variants that are developed that will affect everybody. We're all interconnected. And I don't feel like you need a better reason other than health equity being the right thing to do, but indeed it's the smart thing to do for everyone. And the value proposition, I think we need to emphasize. I think it's wonderful that shooting for 70% worldwide ought to be achieved, and it would be in everybody's best interest.
Thank you, Dean Page. I'm going to move on to another question. Influenza, COVID-19, new enteroviruses, monkeypox. Let's talk about better pandemic preparedness everywhere. What are our lessons learned from COVID-19, and how do we keep funding and attention on preparedness when the memory of COVID-19 starts to fade, which we hope will be soon? Dr. Kirkpatrick.
I guess there's two things to say. I think there's the one that's very hard to fix, and then the other one that's only slightly less hard to fix. The one that's very hard to fix is the forgetting. I think we've seen this, pandemic after pandemic, that when Ebola stops, we forget, and when pandemic influenza stops, we forget. And I think I'd love to have a behavioral psychologist tell me how we not do that, because it's clear that the number one thing we need to do is always be ready. So that's the part I think is the hardest to fix, and I'd love to hear from other panelists if they have ideas how to do that. But the part that I think is so fascinating right now is that we have so many great new tools now with the world that are computationally, that have evolved with our ability to have really better computational tools, better surveillance tools, better techniques. And I think what we're now trying to figure out is how we use them, how we train people to use them, how we understand them, how we get them to be used in an equitable manner, and how we maintain our privacy through that whole process. So I think there's clearly a big, and I would love to hear Dr. Wolfe speak about this, there's clearly huge initiatives for us to figure out how to be better prepared. And I know there's a short list of the pathogens that could be coming next from the WHO, but the tools at play, I think, are totally incredible and hopefully will help us avoid this better in the future.
I'll just add from a more practical standpoint that we were into this pandemic in the United States. There were weeks when I was going to the hospital where we had enough masks to get through the week. So in my entire medical career, if I needed an N95 to walk in a room to see someone, I would grab an N95, I'd put it on, I'd wear it, and I'd throw it away. And we were literally asking people in the United States to save them. We had a plan to how to reuse them, to have them re-sterilized. We didn't know if we had enough rubber gloves, gowns, needles. Our supply chain needs to be more diversified than it was. To that point, we really focused very hard on cost for everything. That was a big driver. And so having a global or a local stockpile to some degree, and then really being thoughtful about that, because literally I couldn't imagine we were in the US and we thought we might run out of masks. So I think supply chain and a strategic stockpile of these kind of things, we have to remember that. We have to not ever let this happen again.
Thank you, Dr. Leffler. Anyone else?
I'll just add to what Dr. Patrick said. So this is an area that I spend a lot of my time working on in Washington. And, you know, historically, as just CDC as an example, when we've been overseas, we built on specific programmatic funding or emergency funding, for example, after Ebola. And when the Ebola emergency funding ended in 2019, we developed a strategy that was really looking at how we could make the US government and CDC's work overseas long-term and not dependent upon these cycles of funding because of what you were saying about the potential for forgetting. And we developed a budget initiative that has CDC overseas long-term in countries and regions as part of global health security, really looking at global health security as a national security issue. So we've been developing that strategy. And what we do is work with countries basically to build their capacity, the core capacities in surveillance and in laboratory and in emergency response and in training a workforce to be able to respond to any disease, because it's very difficult to predict what the next outbreak or pandemic is going to be. So that's how we've been focusing, which is really a strategy to be overseas long-term and work on core capacities in addition to the disease-specific work.
Thank you. Anyone else on this one?
I'll just add another angle. I don't know how to respond to Beth's concern about, I guess, institutional memory. You know, we've been through many pandemics, H1N1, Zika, Ebola. They don't have quite the impact of this more maxi pandemic that we're in now, but at the same time, they should have sensitized us. And instead, over the last decade, we've seen the public health workforce continue to be ratcheted down, not up. We've seen budgets for chronic disease management and for other public health problems to actually not increase consonant with the prevalence in the population. So it is hard to have a little bit of hope there, but at the same time, many are saying, I've seen this show before. I think there are some hopefully game-changing differences now. And I think the game-changing differences are really the connection with other societal issues that are of great concern and that have been magnified as part of what's going on in the pandemic. So the issues of racial justice, the issues of climate change, this new concept called health debt, where people's lifestyle behaviors worsened during the pandemic, increasing their likelihood of having chronic diseases go out of control or even be initiated. And then the exacerbating impact of that on our healthcare dollars, bringing healthcare reform up to the forefront again. So I think all of these other sort of intersecting issues that everyone regards as pretty important and that have gotten a lot of media coverage and attention by the population could help, perhaps, if people understand that pandemic preparedness and management really is critically interrelated with all of them.
Thank you, Dr. Levine. I'd like to turn the podium over to Dr. Kirkpatrick.
I'll carry the auditory clunky version here. Thank you, Dr. Carney. I'm going to ask a more specific question about HIV, and I think this is mostly targeted to you, Dr. Wolfe, but also maybe Dr. Levine and others. We've really made a tremendous amount of progress in the care of HIV and AIDS since I trained in the late 90s with the CDC's global AIDS program, the PEPFAR program. And I know in the United States, we're talking about ending by 2030 HIV as a global health epidemic, which doesn't mean HIV itself will end, but the numbers that make an epidemic will end. And, now we have COVID that of course has sort of challenged all of our healthcare efforts. And I guess I just wanted to hear your reflections on where control of HIV will be going in the next few years.
Sure, and thanks for asking this. Like many of you, I have a kind of personal connection with taking care of HIV patients. After medical school, I went to family practice residency in Sonoma County, California, and I had many HIV infected patients. I remember the first time I wrote a prescription that was not just for AZT, but was D4T, and how good that felt. And I had several patients die, and I was really privileged to be able to work in the U.S. government PEPFAR program for 10 years overseas in Vietnam and Thailand. And that program is the most money for one single disease ever, and has had a huge impact in the HIV epidemic globally. I think that one thing we've been paying attention to in developing basically the COVID interventions around the world has been ensuring that we keep the PEPFAR and the HIV programs going. And we've invested a lot of money and effort to work with countries to make sure that we're not diverting resources away from the HIV program, and we're maintaining those programs as well as we're developing COVID. So it's really important that as we work with countries and push to address COVID, we don't have not just HIV, but childhood immunizations, for example, measles or others, that these other programs don't get hurt. What that means is it takes a long time to build these up because there are limited resources in countries where often they have to decide what they're going to be working on. So it's something that we're paying a lot of attention to. And so far in the PEPFAR countries, we've been able to maintain antiretroviral therapy programs well. And our plan is we're not going to pull back from that.
Wonderful. Great. Thank you. Any other panelists? Insights on HIV care?
Just to put some positive spin on what the CDC has been involved in that translates down to the states. I think real focus on that portion of the population who actually have HIV and don't know they have HIV, and the impact knowing that has not only on their own individual health, but on population health is really critical. And I think if we can continue, at least in this country, to focus on that aspect, there are other priorities depending on where in the world that would take us even further to closer, I should say, to the goal that we have in 2030.
Any other panelists? All right, we'll go from a narrow question to an extremely broad question. And this one is on climate change and health. And I guess this is for all the panelists, is how should we anticipate and prepare for the impacts of climate change on the burden of infectious and non-infectious diseases globally and locally? It's a very large topic.
I'll
Dr.
start.
Carney?
The first is, I think we have to anticipate all the range of health effects of climate change in patients, so that we have to be prepared for that. Everything from heat-related illness to respiratory problems from air pollution, changes in infections, impact of limited food supply, all those things. But that's not enough. I think this is where we all have to advocate for change, particularly for policies that make this better.
I'm interested. I had an opportunity to talk to Dr. Wolfe a little bit about climate change and the perspective of unfortunately, the political nature that some people have to it, and how we can put that aside and focus on the outcomes that we need to prepare for. Dr. Wolfe, do you feel comfortable commenting on that in a purely apolitical way?
Sure. I mean, although there may not be consensus on why things are happening, I think there's pretty good agreement that there are going to be changes in health and health effects due to changes in climate. And I think that we're developing our strategies for that. We have some projects at CDC related to specific diseases, for example, dengue fever or malaria or things, tick-borne diseases that we're going to be seeing. But we're looking at a strategy on how we're going to address health effects related to climate change. And I think there's broad support across the US government for that aspect of the work.
I think Dr. Carney did a great job of sort of listing what we need to anticipate. Some of those actually do intersect with the current pandemic. So if we look at what's called by various names, long haul syndrome, PACS, what have you, the fact that there are sequelae to coronavirus infection, that's SARS-CoV-2. Some of them will involve lung function, lung fibrosis, the ability to breathe well and do the things you want to do in life. And we've already talked about the fact that there's significant respiratory issues when you talk about climate change. Even without the impact of COVID, those will be substantial. So you can only imagine what they will be with the impact of COVID. Food insecurity has really become an issue that has again been magnified by the pandemic. So I think the philosophy of piggybacking on top of the pandemic and really, if I could use the word, exploiting the pandemic in that way can better serve our purposes, for sure. Because I do think there is a consensus that's strongly building in the populace and an appreciation by the populace for the impact of climate change on future generations. I don't think that the political arena, unfortunately, is perhaps accurately representing what the population actually already says. And there's plenty of survey data to really illustrate that point. People are interested in more action, yet the political machinery is not quite poised to deliver in that regard. So I think we need to see a better connect in that way. And obviously public health can be a messenger, can be a siren warning, but it's challenging for it to carry the water, so to speak. It really is in our ability to interact in a policy fashion with our colleagues in the other branches of government.
I'll just take a slightly different spin on it. I mean, if you look at what's happening across Kentucky right now, I can imagine a future where we'll build our buildings much differently, either stand up to hurricanes, tornadoes, or different weather. Dr. Kirkpatrick, you and I are talking about trying to get Lyme vaccines into Vermont. When I was a young person in Vermont, there was no Lyme disease here. The ticks didn't survive. And so I do think there'll be some proactive things that if we think ahead, we can do differently. I would hope that any new buildings that are built in Kentucky in the next 15 or 20 years are not only as tornado proof as you can make them, but have safe spaces for people to get to when they know they're coming. And so I do think that'll be a component of this as well.
All right, thank you very much. I am going to turn the lectern back over to Dean Page.
Thanks very much to Dr. Kirkpatrick and Dr. Carney for leading that discussion. I didn't know that's why we have ticks, tick-borne illness. The ticks didn't survive in Vermont before.
Too cold.
Amazing. So I hope we've already learned a lot. And what's exciting now is we've been answering questions that we thought might be asked, and we wanted to know the answers to. We have another close to half hour for us to hear from the audience. We have a Zoom audience, and we also have an audience here in Sullivan. I'm looking for any hands here in the audience now. We have a microphone. We are recording this. We all want to hear.
Thank you. Thanks for a great panel. I wanted to turn this back. I want to define global here a little bit in the broad sense of cultural understanding and sensitivity. And I wanted to turn back to our teaching of global health and the good comment, I believe it was Jan, but somebody brought up that it's through the curriculum that we need to do this. But my question is, and my thought is, how we need a curriculum for sure, but how do we get students excited about that curriculum? We can have a curriculum, maybe they goes in a circle, but how do you create that excitement? And I just want to take one example, and I'll say this about Mitch, perhaps to his embarrassment or not, but Mitch was an exception. When Mitch was a student, he was the most caring person. It was obvious to me and others, I think, that this is a guy who was going to make some significant contributions to humankind in some way, maybe on a local level or a broader level. But he had an excitement that was waiting to be excited. He did these different adventures, these global adventures. There, he was playing golf before going to, if I remember that correctly, in Scotland before going on to the hospital and practice with the practitioners he was with. But he was waiting to be excited. He had a heartbeat that was just waiting to beat faster, and he was able to find that. And how do we get other people to have that Mitch Wolfe excitement to want to do these things, to want to do something perhaps a little different, and to help mankind? And I just will throw out that this could be through the admissions process. This could be through our teaching. We have a dean. We have different faculty who have taught in different realms. How could we do this? And I'd be interested in hearing from the cross spectrum of people who are involved in different ways. Thank you.
Oh, well, I have one idea. I think there'll probably be more ideas here, but when I did this as a medical student, I spent a lot of time beating the bushes to figure out how to do these international rotations and, connections of connections of connections. It was harder at that time. It was all, I wrote letters, and then got the letters back and really worked it out on my own. If there was some way to institutionalize the ability to get those experiences, those, rotations or internships, I really do think making it kind of easier and more accessible might allow for more people to be able to do it.
Could someone bring a microphone to Dean Anderson? No, we need a microphone to record, please. And then Dean Zala, I might ask you to comment as well. We're getting the whole audience involved here.
Well, first, I want to say how wonderful this panel has been. The discussion has really been wonderful. I had maybe 3 or 4 questions that came to my mind, and each got answered as you all talked. I do want to go back to something that was said in terms of cultural humility as we are looking at the global perspective and addressing the pandemic and other manifestations of health and illness globally. I am struck by how your perspective, I would love to hear your perspective on how bi-directional this can be. Sometimes when you think about globalization, we think about us taking our messages and our methodologies to other places, and with the benefit of all that we have learned. But Dr. Wolfe, as you were talking about your international travels, I'm interested in your perspective about how we can learn from other cultures in terms of cultural humility so that we can address the global pandemic. We all know how health outcomes are much better. Unfortunately, I mean, it just boggles the mind when there is the racial similarity and connection between caretaker and patient. And health outcomes are better in those circumstances. And so I would love to hear your perspective about how we can learn from others as much as we want to them to learn from us, the cultural humility piece of this.
I know one thing I could interject, and Dr. Wolfe, through some of his current and as well as past experiences, could probably put an exclamation mark on this. Great article by Atul Gawande sometime in the last half a year. It was focused on Costa Rica, but it really is applicable to most places in the world that aren't the United States. And it had to do with the role of the primary care practitioner in those countries. And the role of the primary care practitioner, in addition to doing what we would traditionally call the clinical role, was a very, I would say, advanced public health role. They were the arms and legs of the public health enterprise. Everybody had a health minister or whatever title they would be called, but the work, village by village, community by community, would be done within the context of what medical care was. So that a big focus was on prevention, a big focus was on broad public health efforts like vaccination, water sanitation, things that were really at the root cause of many of the diseases that are seen in some of these countries. A very different model, I would say, than what we do in the United States, where we at least have a public health arm and we have a clinical arm, but the integration of those is sometimes very challenged. So I think we can learn a lot, and people who have experiences in some of these locations, I'm sure that would be front and center of what they would notice and could bring back with them.
I can also jump in and say that, you know, and Dr. Wolfe will know better than I, so please correct anything I say. The field of global health right now is really doing a big reflection on itself. And there's a large focus on what they're calling decolonizing global health. And the whole principle that folks from higher income countries would go to a place that is a lower income country and sort of bring their knowledge and their initiatives and their methods is really being flipped on its head, as it should be, to really make it more of an integrated system with learning and knowledge and education going both ways. And I think this is long overdue and really very much front and center at how we all do this type of work and how we need to make it an exchange. What I would say that I think for our students, getting to other societies and countries and places with, even in the US, that have different systems of healthcare and a lot of inequity, I think the exposure is so important so people can understand that what they know and they bring can not only be wrong, but it's presumptive. And so I think this is really a time of reckoning, I think, in global health. And I think, as Mark was saying, some of this, I guess you would use the word exploit the pandemic, but I think it's a good time that it exposes it because it has been needed anyway.
I think we can also make a bridge from local to global. And we teach our students here, we have a global health bridge. I think we're working very hard to teach them attitudes. Always have an attitude of culture of humility and community humility, whether that's a neighborhood, a small town, a state, or beyond. And as the experts in those communities and the students have those attitudes, I think they'll be better served and more open to doing things beyond our borders.
Thank you.
Just a
Dr.
couple
Wolfe, did
quick
you want
things.
to take comment?
To build on that, there is a real connection. I worked at a county health department in California for a year, and there is a real analogous situations between local public health work here in the US and global work. And I think people who are good and interested in global work can do really good at the community level, and people who have worked at a local level can bring a lot to global health. And then the second thing I was going to say is we've been talking now for a number of years about moving more for kind of a donor-recipient relationship. To what countries really want is technical equals. They don't want necessarily us to donate vaccine. They want to be able to make vaccine and do their own studies. And they want to be able to have a two-way exchange of information and really have it be a collaboration. And I think this pandemic is going to help push that forward, because there are many countries that may have done a little better than we did, especially in the early phases of controlling the pandemic, and we actively reached out to them to learn about what they have done. So I think that we'll be able to build on that for the future.
Thank you. And before I ask Dean Zala to speak up, I would mention that the bi-directionality of global health is something that's really been emphasized by Dr. Majid Sadiq, who's at our Danbury campus and leads our global health efforts, that it's not It's not global health tourism. It's truly a bidirectional, respectful, culturally humble process. Dean Zala, do you want to just comment about opportunities that we had before the pandemic and what we might have in the future?
Yeah, absolutely. Thank you. So Krista Sala, Senior Associate Dean for Medical Education. And I think just speaking back to Dr. Land's question about passion is how I would describe it, or cultivating the wonder, that's absolutely what we want to emphasize, that our students have the opportunity to explore their passions. And I think our admissions office does a great job bringing in students who have that passion. The question is, do we have enough flexibility in our curriculum to ensure that they can explore those opportunities? And I think that's what's great about the Lerner College of Medicine, is having that flexibility. So our students, when not in a pandemic, do have that opportunity in their advanced integration curriculum to really do rotations all around the world or within our country. Even during the pandemic, we've had some students recently who've been able to travel within the United States to experience some learning opportunities that they would not have been able to have here in Vermont. So just trying to monitor the pandemic and provide students those opportunities so that they can follow their passion and select a career that's meaningful and that they then will be successful in. And the global health piece, I think, has expanded as well in the last 20 to 30 years. So we have a lot of excellent faculty here, both at our Vermont campus and at our Connecticut campus, as Dean Page mentioned, that have a lot of knowledge in global health with a global health committee. And as Dr. Carney mentioned, we have a global health bridge and a summer fellowship program with our Connecticut campus where students can travel internationally. But I think there's more opportunities there that we can continue to explore.
Great, thank you. I'm going to take a question. I see one in the audience. We'll take one from online, then go to you next. Someone in the audience online mentions that they're hoping to apply to medical school and looking for knowledge or advice as what you wish you had known at the onset of your career in medical education. I'll put our guest of honor, Dr. Wolfe, on the spot, and then open it up to the panel.
That's a great question. You know, when I applied to med school, I hadn't done a huge amount of homework about what that meant, other than I think I want to be a family doctor in a rural town in California. And I think that I was not aware of the variety of experiences and careers that people with an MD can have. And I really would encourage, you know, that exposure to medical students, and even before medical students, about what are all the ways that you can, what are all the opportunities that you may have to do with an MD.
I would agree with that. I mean, if you'd said to me, actually just 4 years ago, you'll be the president of the hospital, I would have laughed at you. But if you said to me when I was applying to medical school, hey, you know, someday you might be running a hospital somewhere, I would have laughed at that. I would have thought that was impossible. So I agree with Dr. Wolfe that explore all kinds of things. You have no idea what might interest you, what might make your heart beat faster, as we heard, and what you might really enjoy for a career. I think a good medical education opens 1,000 doors, and you have to pick which ones you want to go through to have a great career.
Right. Thank you.
This
Yes,
will,
sir. I'm sorry, Dr. Levine.
This will probably get me to the point of never being invited back again. But, everything we do in medical school is really the combination of didactic and experiential, if you distill it down. And there would be people who thought they came to medical school to be a family practitioner and ended up being a cardiothoracic surgeon once they had that experience, and vice versa. And there are people who would have appreciated the didactic of the public health curriculum, but as we all know, it's kind of converged with an experiential curriculum, which is the projects and getting students out into the community and understanding how to actually work on some of the public health problems. Would global health be something similar, where it wouldn't be just you have the didactic exposure, and then if it really piques your interest and you really are very idealistic and want to just do something, you go find the time to do it, write all the letters, and seek out all the opportunities. Or if it was built in, because it was also thought to be something you needed an experiential aspect to, meaning that those who were wise enough to put the curriculum together said, every student needs X, Y, and Z, and global health is one of those. Now, I'm not going to answer that question if global health is one of those, but I think the theme of this session here has been certainly to indicate that it is something that's pretty important. And I think we all know the students we're recruiting nowadays are globally minded. The students we're recruiting really have a lot of this passion and energy and enthusiasm, and they may not have had the opportunities. Some of them actually have had opportunities prior to that here. So something that you would just put on the table as something to think about and chew on in further curriculum committee deliberations.
Thank you. Before we go on, Dr. Kirkpatrick, I promise we will keep inviting you back, Dr. Levine. So appreciate that, Dr. Kirkpatrick.
Yeah, I just wanted to just discuss and maybe rebut's not quite the word, Mark, what you're saying, Dr. Levine, is as somebody that's sort of seen many sides of this, and I would really appreciate anybody's comment on this. When we use the experiential part of medical training with global health, it's often a clinical experience. And a lot of people have extreme passion for doing clinical global health experiences. But as an American trained physician, there's no financial way for that to work. And so I think one of the biggest challenges we have students with a huge amount of passion, but we have no way to make that really part of their career unless you do research in infectious disease, what I do, public health is what Dr. Wolfe does. But there is really not a great way to put the clinical part of global health into the financial model of the American healthcare system. And so I thought for a long time, we need a new way to think about this, a service component of this. But we're really still missing that, unless I don't know what it is. But I would love to hear how other people think through this, because I feel like it's something that we really haven't been able to solve.
Anybody want to respond to Dr. Kirkpatrick?
I don't have any, that's a tough one. But let me just put this
Something to
out.
have some
But
answers.
let me just put this out there. Earlier question, I think it was Dr. Land. How do we get people thinking in this direction and thinking more globally and being global citizens as physicians? And I do think there is a role for, and I would advocate for, more accessibility of M.P.H level training for those in healthcare. And we have a program here. Most medical schools have an accessible program, but there's something about the science of public health and the evidence of public health and thinking in a population level way that influences how you provide care to patients and how you see your own responsibility. So I'm just going to add that to the conundrum of how we fix all these problems.
And I think these things are some of the most valuable experiences that trainee can have. I just would love a way to sustain them. That's, I guess, all I'm saying.
Thank you. We have a question in the audience here.
Thank you. Should I say my name?
Sure.
Marlon Hyde, VPR. So with staffing shortages throughout many hospitals, especially here in Vermont, and also school nurses quitting, how will health services and handling diseases like COVID-19, but also other diseases that are occurring right now, look with staffing shortages and overworked staff that's already employed there as well?
I wish I had the answer. I mean, the whole United States right now is struggling with those exact issues. We have a workforce that is exhausted from the pandemic. We had some shortages to start with. We're probably not training enough of our next generation of nurses and other healthcare professionals right now. So we're working with our colleges on that to try and train more people. And I think we have to rethink about what it means to have a career in healthcare and how we can make sure that people have work-life balance. I mean, they are the most amazing jobs in the world, but we have to make sure that we have enough people being trained Maybe we can lure some people who are getting close to retirement back in for a little while to get us through it. But I agree with you. I think we have some tough times in front of us with workforce challenges. I wish I had the answer. If someone else here does, I'm listening.
Anybody else care to comment?
I don't have the answer, but I do have one data point, which was that last year, according to the AAMC, there was a 19% increase in medical school application rate. I don't know if that spanned any other healthcare professions, but at least the feeder part of getting people into the professions and training them responded favorably at a time of a pandemic. So that should give us a little bit of hope at the very least. I think also what you're hearing is there's a lot of work-life balance issues that have come to light at a time of high stress on every part of the system and every person in the system. And clearly, the pandemic needs to have its ebbing, I guess, not flowing, but ebbing, to let us see how that can be impacted. Because clearly people who are leaving the profession sometimes are burned out, sometimes have just had enough because they've been in the career a long time. And other times, I think if the work-life balance part could be returned, they'd respond more favorably.
And if I might add, there's no profession that can provide such joy and satisfaction as healthcare. But that being said, it's hard to find the joy and satisfaction when you're working as hard as you are. And the key is the pipeline to all clinicians, including nurses, other health professionals, and physicians. Indeed, the number of doctors being educated has increased markedly over the last decade. The problem right now is, even as we have more applications for a relatively limited but increasing number of med school spots, it's the graduate medical education, it's the residency spots that are federally funded and are too few. So if we have more doctors being educated, if they can't find a residency, then they aren't going out into the workforce. So that's another area just in terms of public health that needs to be addressed nationally. I have a question from one of our attendees online, and that's a tough one. What can we do as community physicians and other caregivers to combat medical misinformation on a scale that surpasses our immediate patients? And with 5 minutes left, let's fix this problem.
I face this problem every day. I think the reality is, since it's coming from a community physician, I still think there's truth in the fact that the person most patients trust the most is their own healthcare provider. So, that's like 1,000 points of light, all converge in the right way. But I think that's really critical. I think the current misinformation and disinformation and lack of trust in science kind of direction that part of the country is in is such a big problem. It's not going to be as easily correctable as quickly. I'd like to say you can confront misinformation with data and science, but it turns out it doesn't always work that well. Even when the data and science are definitely clear and true, I think it's a real issue. It becomes problematic because there's a refusal to embrace that on the other side. Sort of piggybacking that onto our VPR question, there's a bit about humanity and civility and respect in all of this as well. You just ran a wonderful series from Northeastern Vermont Regional Hospital on interviews with every layer of the healthcare system, and every person to a T was lamenting what kind of interchanges they were having with patients and interchanges with those who didn't believe in the science that they were trying to practice. So I think we have a huge issue on our hands. It's going to take, I would think, very strong leadership at the top and transparency of communication to help us erode away. I'd love to hear what others have to say, because it is such a huge dilemma, so big that the Surgeon General made it one of the prime parts of his entire time in office.
Anybody on the panel want to make one brief comment before we need to draw things to a close? Dean Carney, or Dr. Wolfe?
Sure. I mean, I definitely do not have the answer, but I know vaccine hesitancy and demand generation is a global issue. It's not only the US. This is an issue for all of the world. And there are different reasons, there's trust and mistrust in who's delivering the vaccine. There's misinformation, there's historical issues, there's inequity issues. And so I do think that we need a multidisciplinary approach to finding out, to learning about how we're going to address this, unfortunately, at local levels, because it's different as you move around. So this is why it's such a difficult problem to address.
And as appropriate, we are giving you the final word. I want to thank the organizers for this really special day with Dr. Wolfe, and for this specific panel, our staff. We could not do anything without you. I want to acknowledge members of our faculty, Dr. Kirkpatrick, in terms of microbiology and molecular genetics and her expertise in infectious disease, Dean Carney in terms of her leadership of our public health efforts, Dr. Leffler in leading our medical center in a time of adversity. And I should mention, I was on the board that hired Dr. Leffler to become president of the medical center. And none of us knew what you were stepping into, but we're so fortunate you did so. Dr. Levine for leading our state. So we have become a leader in terms of really participation and dissemination of vaccines and knowledge within our state. We are grateful to you. And finally, to Dr. Mitch Wolfe for giving us really the gift of your time, your expertise, and giving us a great excuse for us to focus on these very important issues. So let's give them a round of applause here and virtually. And with that, we will close. I wish you all happy holidays, and thank you so much for attending.
That was great working with you.
Yeah, seriously.